Kahan, and today I'm going to demonstrate how to perform a medial branch block. When I'm usually starting in the cervical region, I have the patient lie prone and I have them turn their head to one side or the other. What that does is that usually gets the dental work out of the way and the jaw out of the way, because it's very hard to see through the jaw into people's cervical facet joints if they keep their head straight. So I generally have them turn one way or the other. It does not change your view or your approach, but it just gets the jaw out of the way. My approaches for cervical medial branch blocks and facet joints tend to be through a posterior anterior approach. Although I know how to do lateral approaches, I tend to do things as if I'm going to be performing a radio frequency or setting up for a radio frequency. When we're doing radio frequencies, we know that we have to keep our cannula as parallel to the nerve as possible to create the best burn and best denervation. So therefore, when I'm doing a medial branch block, I do it exactly as I'm doing a radio frequency, as opposed to going to a lateral approach. When I have the patient set up, I always make sure that the spinous processes are midline, that the spine is centered inside the center of our fluoroscopy screen, that our end plates are lined up as best as possible. We can see the uncovertebral joints, your spinous processes, your lateral masses, and then the scalloped area where our medial branch lies. Once I have this set up, I will then tilt it in a caudal approach so that I can see the joint lines. And what we can see here is our joint lines are starting to line up in that area. We then will center the joints that we want to go for into the middle of the screen. And we could see zygapophyseal joint, zygapophyseal joint, zygapophyseal joint, zygapophyseal joint. So right in this view, I could do medial branch here, medial branch here, medial branch here, and then medial branch here. For demonstrations, we're just going to pick this area right here. My approach tends to be of a craniocaudal approach. I'm going to lower the table down so I can get underneath there. Again, trying to keep my eye as close to the patient as possible. Over here, I'm not really happy with that, so I'll come out and then reposition it. I'll reposition it because I can. The patient has a skin wheel. They're anesthetized. Always try to make sure you're over the area that you want to be at. As you can see in this view, my hub is way cephalad compared to my needle tip. So I will spend the time just at the skin to get my hub over my needle tip as best as possible. All right, that's starting to look a little bit better. As you can see, my hub is over my needle tip. My needle tip is pointing out to the side here. My end goal is right there. So if my needle tip is pointing to the right and I want it to go to the left, I have to rotate it so that the bevel's to the right. Well, the bevel correlates with the notch in your spinal needle. So that means my notch has to be to the right. So I'm going to go reach down. I'm going to move my notch pointing towards me, which is to the right. And that should direct my needle medially, as you can see. We're now kind of good medially. We're now going to direct it up superior. So that means my notch has to go down towards the feet, which will point the bevel down, which will make my needle go superior. And we're going superior. Now I want to just touch the bone right here. That's your end goal. Bone is your buddy. Bone tells you where you want to be. So make sure you aim for that bone. So we're going to adjust the needle medially. And I can feel that bone right there. I just can feel it underneath the skin. So once I've approached that lateral mass there, I'm then going to go to a lateral picture and I'm going to adjust my depth in a lateral view. And as you can see, the needle tip is sitting right here. We want to be there. So in this lateral view, I'm just going to advance it a little bit. I felt myself slide off the bone, and I'm going to stop. That's your medial branch block. Now, what's the nice way of doing this approach? Because if I wanted to do a radio frequency, I do the same thing. So that's why I perform my medial branch blocks as if I am doing a radio frequency. It constantly causes you repeating the same procedure over and over and over again, so you get more and more experience. Yeah, you can go from a lateral view and use an 1.5-inch needle. That's fine. Patient lies on one side. After you're done with one side, you turn them over, they do the other side. But you know, when you're doing a medial branch block from a posterior approach with a 25 gauge needle, okay, 3.5-inch, doesn't matter. They're going to be anesthetized, they're not going to feel it. The advantage of this is, in doing this approach, I've reiterated my experience of doing radio frequencies. So every time I'm practicing another technique by doing the same approach. If I wanted to do an interarticular injection, I would do the same approach, except I would just land further back here. I'd be aiming for that part of the joint to go into. So that's really the only difference between an interarticular and a medial branch block. And the only difference between a medial branch block and a radio frequency is you're using an RF cannula. The approaches are the same. So the more you repeat the same procedure, the more expertise you're going to get at doing it, and it'll make it easier for you to move to the next step. Thanks.